Good afternoon to those of you on the East Coast, and good morning to those of you that are joining us from the West Coast. My name is Angie Halverson. I'm with Apt Associates, and I'm a part of the VHITS project for SAMHSA. We will be starting our webinar in 1 minute. We do still have a few folks joining us, so we will pause here, allow our remaining attendees to join us, and then we will get started with our presentation. At this time, you will hear silence until we begin.
Why are we not going on mute?
Because it's my computer.
I want to thank everyone for joining us today for Building a Roadmap Part 2, Innovative and Integrated Treatment Models, Increasing Impact of Opioid Treatment Programs Through Care Coordination. Good afternoon to those of you on the East Coast, and again, good morning to those of you joining us from the West. We are here today. We are going to discuss integrated and innovative treatment models, and we're excited that you're back with us, hopefully, for Part 2. This is the fourth in our webinar series addressing care coordination and OTPs. Before we begin, a few housekeeping announcements. Our webinar is being recorded and will be posted to SAMHSA's YouTube page. We will provide participants with a PDF of the webinar PowerPoint slides. At this time, all lines are muted. I would like to ask that all comments or questions be submitted via the chat box on your GoToWebinar toolbar. At the conclusion of our session, we will have a brief Q&A session, and we will facilitate those questions for our panelists. Again, welcome to the Care Coordination for OTP series. This is SAMHSA's 5-part series. We have been holding these webinars for monthly over the last 3 months. This is number 4. We will have one more webinar that will conclude our series that will take place in August of 2018. Again, all sessions are recorded, and we have posted our previous sessions to the SAMHSA's YouTube page. Our next session, held August 9th, will be action steps for implementation, and our goal for that webinar is to wrap everything up that we've been discussing over the previous 4 webinars and deliver a set of action steps for implementing care coordination for OTPs. The webinar will be held from 1 to 2:30 p.m. Eastern Time. We will send out a registration link via the Health IT Webinars listserv 2 weeks prior to the webinar. Please email healthitwebinars@abtassociates.com to be added to our list. On the screen here, you see our agenda. So we will begin with Using Technology to Improve Care. It's a presentation by Ray Tomasi from Gosnold on the Cape. We will follow that with 3 models of care coordination by Linda Hurdley, CEO of Kodak, and then we will close with open discussion and comments and final information about our last webinar to be held in August. At this time, I'd like to introduce you to Ray Tomasi. He's the president and founder of Gosnold Innovation Center, Gosnold on Cape Cod. He's going to be talking about the technology to improve care, and I hope that you enjoy his presentation. The information he has to share with you is incredibly fascinating and obviously very relevant in our technology-based age. Ray, I'd like to turn it over to you.
Thanks very much, Angie. I'm happy to be here today. It's a nice day in New Jersey, where I am actually doing this from, but also on Cape Cod. By way of background, I have worked in this field for over 40 years. 25 of those years as the president and CEO of Gosnold on Cape Cod, which is a multi-component behavioral health organization with prevention, treatment, and recovery services. And following a transition and succession planning, I have instituted what we identify as the Gosnold Innovation Center, and I spend a lot of my time now working with folks who are thinking about new ways to approach care, to organize systems of care, and to deliver that in the new age of addiction treatment and healthcare. So just to touch on some of the points that we want to try to cover in my time today. I'm going to give a little bit of context for this discussion and talk about what I see as some trends in the addiction treatment field, because it is a rapidly changing field. And then what is the role of technology in that new system or paradigm, and how can technology be better used to coordinate care across the spectrum. I will give you some examples of some options, technology options that we've used, that we've tested, and how they have impacted our ability to think about coordinated care, and also how they've impacted some of the sort of the philosophical frames that people have existed in for many years in our field. And finally, what I believe are some barriers to implementation, some of which I've encountered personally through our own initiatives and others through talking with folks that are doing similar types of activities. So I hope this is useful, and certainly this is a snapshot of how we see technology's role. Many of you who are listening to this today are doing your own thing and figuring that out. So I hope this expands a little bit your thinking and helps you make better decisions in the future, because this is an issue that is here to stay. So having said that, let's just put a little context on this. Certainly the opioid crisis has really driven interest, as you all know, in our field. The current state of activity is very broad across multiple sectors. It has done a few things in terms of helping us understand and helping us have society understand. So I think we're seeing an increased understanding of the chronicity of SUDs, this historical frame of kind of like, go get some help and then that should do it and you should be fine, which has contributed to great misunderstanding. I think that's changing. I think we've seen a general dissatisfaction with outcomes, and even changes in how we define outcomes. And I think that controversy is still going on. We're talking more now about periods of remission and improved functionality, and the idea that someone would never use substances again, and that essentially would define success or failure. I think that's a changed concept. Certainly absence of use is our objective, but recovery is being seen as more, and the idea of lifetime management of a chronic illness is becoming more apparent also. And I also think that we have had some changes in our field, but for the most part, we've had a static model of treatment, essentially defined by inpatient care primarily, and then hopefully a transition to an outpatient service. But I think that as we move toward a broader accommodation of population health, alternative payment models, as systems begin to recognize that costs to them and risk of the risk that they're assuming in some of these contracts, the incredible comorbidity costs with both mental health and addiction is forcing the healthcare system to think about this in a more comprehensive way. So what we see and what we've experienced is a move toward application of interventions and ideas around the chronic care model, with early intervention, prevention, integration with primary care and specialty care practices, hospitals, emergency rooms. These are things designed along the lines of how one would manage chronic disease. So you try to identify earlier, do interventions earlier, and hopefully have better outcomes. On the other side, in terms of reductions in readmission, we're seeing extended patient engagement. Recovery coaching is widespread. Whole family involvement is something that we've all done, but I think that would be better defined by talking about whole community involvement, so that understanding that the social determinants that impact outcomes with this disease are significant. And so with respect to coordinating care, we'll be talking an awful lot about coordinating care in an internal organization, but certainly the future is to coordinate that care with similar entities in the community that contribute to the health of the patients that we serve. Medication is as medication is, and the controversies will subside. We won't touch on that an awful lot. I know Linda's going to talk a good deal about that. Certainly much of what we're seeing is being driven by alternative payment models, the need to begin to think about taking on risk, about collaborating with larger entities, about looking at bundled payments. All of these things that take us away from the fee-for-service environment and the episodic delivery of care will force us to think about ways to stay engaged over time to help our patients stay in remission. And I think that's the place where technology has great potential. And so technology, both in terms of intervening and assessing, treatment, monitoring, these are all very real things that we can no longer sort of pretend that will not change our field. They will definitely change our field. So that's what we're up against. And then, I've added this. It's a sort of repeat of much of what I just said, but I wanted to put it on because it's important to mention the Surgeon General's report. And if you haven't read it, you must read it because it is, in fact, I think, a blueprint for the future of treatment prevention and recovery. And there are references throughout that to the need for coordination of care, for full spectrum addressing of problems, for connecting and collaborating with other entities. And you can see in the middle of that, leveraging technologies, whether it's patient portal or health information exchanges, treatments, assessment, patient monitoring, all of those things lend themselves very, very sufficiently to technology. So it's a long report. You don't have to read it in one setting, but it is something that should be dog-eared over time because it is very, very relevant to what we're doing today. I often go outside of the behavioral health field to look for ideas, and not that this is generally a new idea, but I wanted to just sort of refresh our thinking about care coordination and particularly point to some key words that I think are relevant to our field. And I think if we go down this list very quickly, the key words here, one is continuous. And I think continuous is, versus what we have historically looked at as siloed, episodic care elements. The continuous nature of our need to stay connected sort of defines the chronicity of the disease that we treat. Customization, customized service delivery elements. And I think this is very much sort of patient matching, patient-centered, not the historic one-size-fits-all idea that has been prevalent in our field for many, many years. The idea that the patient begins to be the source of control. So bringing the patient much more actively into decision-making around their care, the direction of their care, as opposed to a more prescriptive approach. And technology actually plays a very big part in that because the patient has the device in their hands, and they, in fact, are making the decisions about when to use it, how to use it, and how that information gets shared. Shared knowledge, free flow, that's sort of inherent in the whole concept of coordinating care, but it does run against what has been the historical sort of vertical hierarchy of thinking and decision-making and information that has also, I think, been tantamount to how we have delivered care in the past. In other words, we've got the idea, here's what you do this, and things will be better, hopefully. Evidence-based, I know it's a word that's tossed around, but I think it's certainly important to talk about that and to incorporate that kind of thinking into all the decisions that we make. Anecdotal experience, sort of academic readings have to be put to the side, and we need to do things that have been demonstrated to work. the other point I'd like to make on this slide is actually the anticipation of need. And I think what we're talking about here also has to do in some way with the idea of predictive decision making. Can we begin to have a way to anticipate when patients are going to need interventions well before the crisis emerges, and then that intervention has to happen in the moment's time. So I think historically we've had more of a retrospective view of things, but the idea of anticipating, predicting, and it's another place we'll see where we've tried out some ideas and technology that can help us do that and head off crises or limit the damage when people have regressions or relapses. And finally, collaboration. I think this is easily said, but sometimes difficult to do because historically there has been sort of the ownership of the patient, if you will. What we're talking about now to really affect better outcomes is not only cooperating, but collaborating across the spectrum, both internally, and that's sometimes not as easy as it sounds, and externally with the community resources that our patients need and utilize. So this is, obviously it says from cancer care, but all of these things are very, very applicable to what we're doing and terribly important in linking with technology. So, you know, just what are we facing and why technology other than the fact that it sort of exists? There's some really startling pieces of data that I would refer you to. The most critical, I think, and the one that got me very interested in technology were the projections about workforce shortages. I don't have to tell any of you that getting good qualified people to work in your organization is not an easy thing. The HR person is now one of the most important people in our organization. But to put some context around this, the projection, you could go to the November 2016 National Center for Workforce Strategies document projecting about a $225,000 person gap by the year 2025. Those gaps, 75,000 mental health or addiction social workers and counselors, an equivalent number of school counselors, school and clinical psychologists. So we have a workforce shortage that, in my view, we will never be able to hire our way out of. The same goes for psychiatry. You know that, many of you know this, but to refresh you, 60% of the counties in the U.S. do not have a psychiatrist. And this was actually a surprise to me, but a third of all of the psychiatrists providing care in 2015 were from a foreign medical school. Immigration is terribly important for our field. That you may want to go to something called the New American Economy. It's from an October 2017 publication. So we need to figure out a better way to deliver care. And we know that in our experience, technology can improve access in hard-to-reach areas, particularly rural areas. We have a clinic on the island of Nantucket, which is a great place to go, at least for 10 weeks during the summer. Let me tell you, in January and February, it's not exactly a destination. But that certainly can help, particularly in areas that don't have qualified face-to-face opportunities. This whole idea of extending the relationship with patients and engaging with them between face-to-face sessions, what I call a digital loop. We'll see how some of that has affected some of the things that we've done. Again, we've talked about locus of control. The other issue here with technology is that we do have the capacity through some instruments and tools, technological tools, that have the potential to improve access to care by giving clinicians an additional tool to help them complement face-to-face sessions. So that if you are doing things in between sessions, either or the patient is, and you're able to see what they're doing and you're able to engage or communicate with them through technology, is it possible that instead of seeing that patient every 2 weeks, you can see them every 3 weeks because they have something that you're involved with them in between sessions? And will that open up more access for people? We believe that it has the potential to do that. The other thing in terms of convenience is that technology reduces a burden. People have trouble getting to clinics. They have trouble with family issues, and the idea that they could engage with a clinician or engage with a device that is guiding them and helping them opens up great possibilities. And then least of all, of course, is that everybody's on their phone anyway, so why not just join the club and do something that's on the phone? So we have a lot of potential with technology to overcome some of the real difficulties that I think we presently have in our field. So there are a number of things. Some of the examples I'm going to go into in a few moments are going to touch on these, but just as I don't need to really read these, but as the screen shows, these are some of the functional roles that technology can play, both in delivering care and making assessments, in tracking patient both progress and day-to-day activity. GPS tools, which we've used with some success in helping patients identify and avoid high-risk locations. We won't talk too much about wearable devices, but I wonder how many of you have a Fitbit on. I keep losing them, so I've stopped trying to do that one. But there's great. I think there's future there. There's a lot of work being done. And then, of course, text-based reminders. I'm sure many of you are doing that. You may want to reference that because I don't have this in the reference list at the end. I just happened to come across it the other day as an interesting piece in the Washington Post. It's called From Apps to Avatars, New Tools for Taking Control of Your Mental Health, which does a pretty good job of addressing this issue and identifies some of the tools that are being used right now. So this is what some of this is certainly, all of this is presently being done, but I think we've only begun to touch the surface of this. So trying to get to the next screen here. No, not moving. There we go. Okay. This was surprising to, well, a little bit surprising to me. This is a study that was done in Philadelphia, and we talk about that. Sometimes I hear, well, people really don't want to do stuff on the phone. They want to talk to a clinician. They want to have a face-to-face. Yes, they do. But look at this. The striking thing here for me was that this was a study done among individuals who had annual incomes of less than $10,000. So, I mean, initially, 94% of them have a mobile phone. Almost 3/4 said they'd rather use an app on their phone as a relapse prevention tool. And half, we're talking about allowing clinicians to monitor their progress through social media through a phone. So we have a population, not just a young population. Also, I think one of the things I saw recently that I think it was 72% of the 18 to 44-year-old demographic would prefer to engage in telehealth sessions rather than seeing a counselor directly. And even amongst the over 45 group, that was about 43%. So we have a environment that is ripe. We have a population that is willing, and we are at a place where we should be ready to do something. So what I'm going to go through are 4 or 5 technology devices or approaches that we have used. We'll talk a little bit about them. I'm not going to say much about telemental health, but many of you are doing that. We're certainly doing that. But I want to talk about some of these other things, which include clinical progress tracking, engagement through apps, the delivery of treatment, measuring outcomes, and then contingency measures. So basically 5 different areas: progress tracking, recovery management, actual CBT delivery systems, and then an outcome app, and then a contingency management app that we'll talk a little bit about. So we've been involved with this product called Tritium. Now, I'm going to be referencing the 5 specific products that we've been using. They are products that we use. There are others that do similar things. The point here is really to talk about what they do and how they can help in the coordination of care. So Tritium is actually a tool used to measure progress for patients who are already receiving treatment, primarily in an outpatient setting. And so the idea here was, and thinking about this was, can we come up with something that will complement clinician subjective view with something that's objective and comes out of a reliable instrument, so that we can pair those two to make better decisions about how to deliver care, and the frequency, the intensity of the care, as well as the step-down potential of some of these instruments. So basically, a patient completes an assessment online. It takes them through a series of screens. It ends up creating a BHI, or a behavioral health index. Now, that index is individualized to the patient, but the system then, and because it has millions of data points, and it's been around for a long time, has essentially is able to take that profile and create an expected progress trajectory over time, over a period of 3 to 6 months, and then plot the patient's BHI against that trajectory. And so the clinician can actually look at, so they do this every time they come in. The clinician reviews it with the patient, and the patient can see where they are relative to the expected progress. And they can also see where they are relative to specific issues that emerge as part of the assessment screen. All of the clinical team members have access to this data, the doc, and the supervisor, and anything that sort of goes into sort of the red area gets alerts to, all the alerts go to all the clinicians. It also goes to the supervisor, and so that hopefully there's an intervention that can occur in a timely way to set off or to avoid crisis. So there's also an analytic part of this that enable you to aggregate data. You can aggregate data. You can look at BHIs and progress trajectories by site. You can look at them by diagnostic group, by clinician. We've used it in some ways to look at, say, take a patient, all the patients that are being treated for depression. We can segregate that information against by clinician, and you can start to see whether some clinicians seem to be having better success or better results, if you will, with patients who have depression versus patients who have anxiety. You can then talk to those clinicians about what approaches they're using that might be useful to other clinicians, or you can begin to direct patients to clinicians who have demonstrated particular expertise or results with specialties. So it gives you an opportunity to parse the data. As you know, any of this data can be sliced and diced until you're, out of your mind, I guess. But it's a very, very, I think, interesting tool. And what it has to do is progress tracking. So something for you to think about. Many of you, or some of you, may be using this HS. It's called HSTap. It stands for Addiction Comprehensive Health Enhancement Support System. So you know why they call it HS. This is a monitoring tool. Was developed at the University of Wisconsin. We were involved in the very, very early stages of their prototypes with this app. It has some very interesting features around patient linkages and coordination. You can do online support groups patients can do. They can tie into testimonial talks, AA, NA meetings online. There are all sorts of recovery aids that they can do with meditation. What we like about this is they do a weekly survey. You can see the scale there. We've set thresholds. Anything above a 5 gets an alert gets sent to the coordinator that is managing this, and then we can operate on the basis of that information to reach out to a patient. There's a little beacon light at the bottom there is essentially a panic button. If someone hits that, it will go to a next screen which says, would you like to talk to your counselor? The other thing about that is that alert also goes to the coordinator, so we know that someone is hitting it if they're in crisis. It has a GPS feature that allows the patient to load in high-risk locations. We actually do this. We load this app onto patients that are receptive to it while they're in an inpatient setting. We do a group that explains how to use it, and then there's a point person that manages that population. It's actually been, it's like a lot of other things where you have to sometimes prompt people to get involved, to stay involved, but this is another device that we have used in order to create and close that digital loop, HS. This is called PAR, P-E-A-R Therapeutic. This is actually an online treatment app. We have it's an interesting approach this company has taken. It's actually the first FDA-approved app. It was approved, I think, about 6 or 8 months ago. We've done 2 pilots with this app, and we're now in the process of discussing the next stage of implementation and application. This delivers a CBT, series of CBT modules that the patient and the clinician determine together as to how it will complement the sessions that they have. It also includes some self-monitoring features. You can't see it because it's blurred, but over on the right, that little phone app has a series of things where someone rates how they're doing in these areas. And basically, it's the HALT: hungry, angry, lonely, tired, social pressures, pain. They rate themselves, and this information has both a patient-facing and a clinician-facing screen, which exists here. So the patient has access to a number of CBT modules. I'll show you what some of those are in the next slide. There's a contingency management feature to this, so that successful completion of a module will result in an opportunity to win a gift card. That sort of hopefully will keep people coming back and engaged. On the physician or therapist side, we can see what modules the patient has completed. We can see how long it's taken them to complete. There are little tests associated with each of the modules. You always pass the test, but if you get a wrong answer, it takes you back and refreshes your knowledge base about that particular issue, whether it's triggers or craving, relapse, whatever. A clinician can see the graphic representation of the cravings and triggers scale, and you can also see whether or not appointments have been kept, whether drug tests have been passed or not passed, and all the team has access to this information. So again, the idea here is, can we both deliver care and influence and intervene with progress limitations or progress setbacks? These are just a handful. There are like 60 some modules. This is just a sampling of what some of those are. PEAR, treatment and education. So very interesting potential for this particular technology. I'm going to have to step up here a little bit. Now, recovery track. we're not going to show this video. You can go to YouTube, put in Recovery Track, the Centers for Innovation, and you will see about a 3 or 4 minute video that will tell you about this. We've used this primarily in our recovery coaching program, and what it basically we have patients. There are a number of ratings and feedback potentials in this app. We have been using this for about 3 years, and we are able to, every 2 weeks, our coaches initiate a patient response to these feedback questions. We actually measuring outcomes and progress in about 20 different domains. Those results are graphically represented, and then our coaches essentially sit with patients and review them, look at trends, look at ups and downs, and the patient can see over time how they're doing. It has a very interesting, this is an example of how, one of the ways in which we've used this, because you can correlate 2 or 3 different domains. This is an example of a situation where you can see that the dotted line is patient perception of risk. The solid line is their report on attendance at self-help meetings. You can see the obvious things here, but the more obvious thing is that what we have the potential to do, or what you could do if you had something like this, is you could do something well before those 2 lines intersected, and hopefully head off and intervene in a situation that was going to be problematic for the patient. So this is another device that is connected both to the coach, the counselor, as well as the prescriber, if there's a prescriber involved in the case. So this has really to do with connecting the internal team. I'm going to run quickly through this because I'm going to get to the barriers, and I only have a few minutes left. Dynamic care, we've done two pilots. We're presently in the middle of, or just starting, a NIDA research project with this app. This is also similar. We're using, in this case, however, we're using contingency management in a very big way here, so that appointment adherence, medication adherence, AA or NA, time in, time out adherence results in a reward. I'll tell you about that in a second. This also has the additional potential to do breathalyzer or videoed breathalyzers and saliva tests. Random alerts go out to a patient because you need to do a test right now. We equip them with saliva kits, and every time they do one, you can actually see the result immediately, and they get a reward. So that actually has been very well received. I was a little skeptical about that part of it, but it's been very well received by patients. The rewards go into a controlled debit card, which can only be used in limited settings, and also the spending patterns are tracked by the system, so we can see whether someone has made efforts to use it at an ATM machine, whether they have done compulsive spending somewhere. And again, this is another device that's connected internally both to EMR, so that the clinicians can see what's going on, as well as to either coaching staff or to the prescribers. There are a lot of other things out there. These are some of them, but you go on, there's just tons of these. And I think one of the challenges is, how do you decide what to use? Some of you may be using some of these and with success. So lots of opportunities out there. I want to touch on, I think I have a couple of minutes here do I have a couple of minutes? Yeah. To touch on these, because I think there are some significant barriers, not the least of which, surprisingly, is really the reluctance that I've seen on the part of many to adopt some. I mean, adoption is always difficult, change is a challenge, but it has been a challenge, I think, to convince both clinical and support staff that some of these things are not there to sort of replace you. They're there to help you and complement. No technology is going to ultimately eliminate the need, I would hope, for human engagement. But it's been a little bit, I think, sort of the silo mentality. Even in our own organization, we have multiple levels of care. Getting those silos to be sort of broken down and connected and linked has been a long process, and it has to be continually reinforced from leadership at the top. Of course, we won't talk much about reimbursement, but that's always an impediment. We've had the good fortune of having philanthropic support for some of the efforts that we've been able to try that have not had reimbursement methods. 42 CFR, you want to look at some of the new regulatory, the changes with respect to how that may impact your ability to use technology and share information. We've been talking about internal sharing. There are also pretty significant challenges with interoperability and sharing information across systems and outside of your own systems. But these are the challenges. Yes, they are, but they will be overcome because they have to be overcome. There are additional analytic requirements that are required in being able to best utilize this information and then use it to be a decision-making tool. I think the idea that we all talk about how we're making data-driven decisions, but when the rubber hits the road, there's still a lot of sort of instinctual response to things and sort of going the way things have always gone. Someone has to be willing and able to look at the data, analyze the data, and feed back the data to clinical staff. We have had a couple of different runs at that. Supervisors have been okay in the beginning of that, but haven't been able to sustain it. Our best results have been when we've had a coordinator that's looking at the analytics and then feeding back information to patients. And one last thing I wanted to point out is an incident, not an incident, but something that happened with us some time ago. And this gets to the sharing of information part, where we had a patient that was being seen by a counselor, had a recovery coach, had a psychiatrist, and also had another caregiver involved in their care, and the patient happened to share something with a clinician about an incident that had occurred, but said, and when that information was learned by her recovery coach, she was very, very incensed that somebody had broken her confidence. In fact, the clinician was concerned that her relationship with the patient had been compromised a little bit because it was no longer something that she and the patient were exclusively privileged to have. So to begin thinking about a care team, and I actually met with that patient because they were that upset when I was the CEO, and I realized that we really have to start to talk to patients about a care team in a way that we haven't been, and I think that's because there isn't really ownership of patients here. It's individual ownership by a clinician. When you begin to share information and use these tools to do it, it's important that everybody be on board. And finally, of course, you've got to get people who want to use technology. That 4 or 5 years ago, that was an issue. That has not been an issue for us now. Patients have been much more ready to adopt some of these things, particularly as they see them augmenting, complementing, and supporting their care. So with that, there are a number of references here which will take you a little deeper on some of these, and I would particularly point out the work of Lisa Marsh at Dartmouth and Kathleen Carroll at Yale, particularly advanced in they've been looking at this for a long time and have done some really great work, and they can be very informative pieces for you to go to. So I hope this has given you a bit of a snapshot of at least how one organization sees the future a little bit and some of the ideas that we've been able to apply and practice, and how all of these things are going to make it much, much more productive for us in terms of taking care of patients, helping them manage their disease over their life, and using tools that don't overburden and stretch out our staff that is really sort of at the end of it anyway. So, and with that, I will turn it back.
Great, Ray. Thank you so much. That was a wonderful presentation. We're going to move right into our next presenter at this time. I would like to introduce to you Linda Hurley. Linda is the president and CEO of the Kodak Behavioral Healthcare based out of Rhode Island. She's going to talk to us today about the financial and regulatory considerations in 3 models of care coordination. Linda, it's great to have you back. Linda has presented for us 2 previous webinars, and she's building on the information that she has previously presented to us. So we're excited to hear where we go with our financial and regulatory considerations today and how to overcome some of the barriers facing our providers in these 2 areas. Linda.
Of each of the 3 initiatives that we've been discussing through the course of this webinar series. And then I'll move right into really talking about the challenges and the lessons learned. This is from our perspective, was very practical learning. So as we begin here, okay. There we go. All right. So sorry for the delay there. The first initiative that I'm going to be talking about is an initiative in Rhode Island that was the first of its kind in the country. And it was enhanced medication-assisted treatment at the Rhode Island Department of Corrections. Kodak was fortunate enough to have a long and extended, or expansive, I guess, relationship with the Department of Corrections in Rhode Island. This particular picture, I really just enjoy it because Andrew Joseph was writing for the Boston Globe and spoke to the effectiveness and almost like the, I would say, ethical imperative to provide medication-assisted treatment for the disease of opioid use disorder to those who have been incarcerated, just like we continue to provide medication for cardiac considerations when someone is incarcerated. So the goal of the program was to decrease mortality. And we were going to decrease mortality, defining decreased mortality as the mortality component for this population in Rhode Island was in 2015, 21 to 24% of those who died from opioid overdose death had recently been incarcerated. So almost a full quarter of those who died from opioid overdose in 2015 were this highly vulnerable population who had been recently incarcerated. And for those of you that are in the field and working in opioid treatment programs, it's probably quite clear why that would be a vulnerable population. So all we needed to do that was identify those in need, initiate MAT for those defined as in need, and increase retention and treatment post-release, which we did, to the point that the most recent data has been published that there has been a 61% decrease in opioid overdose death in this population since 2015 with this program. The program itself was the only one in the country until very recently. Rikers has added some medications, and the New Jersey Department of Health has added medications. So they're also providing methadone, buprenorphine products, and naltrexone products. In addition to using the 3 approved medications, we have a co-located opioid treatment program, CSAT approved, DEA registered, which begins to speak to some of the regulatory issues we faced in doing this. The other piece that is somewhat different is that we are providing this to all patients in need, not just those that are coming in already maintained, also those that we're doing it for people pre-release if they feel that they're going to be at risk. So let's move to financial considerations. I'm going to try to keep us on time here. The first financial consideration, for those of you that do grant writing might know the term soft cost contingency line item, to try to create a budget that is fluid for an evolving program in an environment that we have not been in before was really a challenge. One example of that challenge is that we scheduled our ASAM physicians for assessments 8 hours a day for 3 days. Which if you're looking at a community OTP, that would be a very normal thing to do. We really wanted the expertise in the beginning of the program because we were setting up and vetting protocols, and we also needed to be seen as legitimate, and that's very important when you're going into a setting that is quite different and isn't primarily rehabilitation. So in a non-correctional OTP, make good sense. What we found at the prison, at the very, very most, we could use 50% of an 8-hour day of physician time for direct care due to the lack of availability of the inmates. And we learned a term as we initiated this with our partners at the Department of Corrections, which I'm going to start to use DOC at this point, and that was lockdown. And it means that all inmates must be in their cells. It's about safety and security. So that's very often scheduled, but sometimes not scheduled. If, for example, correctional officers needed to be elsewhere. So with security always being primary, we would end up with a scheduled time with inmates/patients, but they would be unavailable. So we were wasting expensive doctor time. Another challenge that we found was that recognizing that Kodak as an OTP, as a vendor in the correctional system, was a guest. And we were a new guest, and not everybody had invited us. So as with any organizational change, there were serious challenges. Not all departments, buildings, leadership, or staff were supportive of MAT in the first place. And some actually saw our presence in providing this care as a threat to security in terms of diversion of medication and medication line security, inmate flow issues. So we found that in this environment where there was a full range, 180 degrees of support for the rehabilitation services we were providing, that the requirements for all staff, the individuals needed to have experience, hopefully in a corrections setting, really strong interpersonal skills, and the ability to act as an ambassador, in addition to holding the skills of their professions. This is not a program that can support entry-level staff, unlike our OTP staffing configuration. So our learning here was it wasn't just wasted doctor time, but also we needed to, the HR cost was much larger than we anticipated because of the level of skill and experience required. And one of the third major financial considerations we found was that integrating the missions and goals of multiple groups and agendas, resulting agendas of multiple groups, was time and staff intensive, and that really resulted in delays. I'm going to give you 2 examples that ended up being quite costly. One was the union for the DOC nursing staff was concerned about maintaining positions for their nurses. The resolution for this resulted in a delay in optimizing those positions we'd hired, and we ended up overstaffing for a period of time because having a vendor come in to do nursing tasks was perceived as a threat, as I say here, to the optimization of work availability for union members, the nurses. And that's the mission of the union. It was fine. But we ended up paying for expensive RN time for 6 months, because that's how long it took to resolve the union issue. Totally unanticipated. Another was the actual placement of the dispensary, which took much longer than anticipated due to logistical and safety concerns, changes in staffing, also what I would refer to, not in a demeaning way in any way, but turf issues. People were concerned if they gave up space, it might be space they would need in the future. And when I say people, I'm talking departments, buildings, staff. So we ended up being caught in the middle a little bit around the Department of Corrections middle management directions and executive leadership directives. These delays resulted in some serious and costly issues. As I say in the last bullet there, for those of you that have opened an OTP, we actually ended up having to have the safe delivered twice because the positioning of the dispensary was changed due to all of these things. And frankly, the cost of the safe is expensive, but a third of that cost is the delivery. So how did we address the financial considerations, the three that I had just talked to you about? There's some basic principles. One is communicate, which we talked about before, communication with leadership and stakeholders, all of the stakeholders and all the multiple groups. And we have to focus on immediacy and immediate reconciliation when possible. Also, this soft contingency or unanticipated costs, we needed some redundancy for the grant funding. And you have to work very closely with the contractor. We had to work very closely with the contractor to be very clear about what those needs were. We needed to utilize care coordination to optimize dollars. An example of that is as we expanded, we needed more doctor time. So we collaborated with the DOC and worked towards training some of the DOC docs, not just our Kodak or vendor doctors, so that those DOC doctors could assess and write orders, and those could then be acted upon as long as the Kodak physician or medical director had approved that order. So it cut time by at least 90%. And we were able to expand services that way. So that was one innovative way, and why I keep going back to communication and relationship. As long as there is regular communication with those in decision-making places, we were able to work through these challenges in a time-effective way. And the last two bullets, it is just absolutely important to promote ourselves. I'll say this 3 more times throughout the course here, that we have to publicly self-promote, talking about the need, how we're meeting it, and what the outcomes are, so that the community understands the effectiveness and importance of the work. In terms of physician time, this was just a very practical piece. We just hadn't thought about it. So working with our own Kodak physicians, we expanded the number of days present and decreased the amount of hours. That way they could be there when we had the best shot at having inmates available for assessment and treatment. Also, we needed to become more proactive in understanding what's important to the environment in which we were entering. So, clearing and orienting our physicians through the Department of Corrections so that they could provide services there. There were times that this orientation process would be delayed maybe 6 or 8 weeks, so we would be paying for a physician, again, overstaffing, that could not enter the correctional facility because they hadn't been cleared and oriented yet. So various, and I believe that each system is probably different. If you're looking at co-locating an OTP or providing services, MAT services in a jail or prison, I would imagine that there are as many systems as there are jails and prisons. Each one has its own personality, its own interpretation. So my suggestion here and what we learned is that we did not understand that well enough going in. And that's where a great deal of waste occurred, as well, as anxiety. So And the other piece that we are now working on is securing CSAT waivers for mid-level practitioners to provide a full range of MAT, a full range, not just buprenorphine, increasing redundancy and decreasing cost. In terms of the HR costs of staff overall, that was a real challenge, particularly when, at least in New England, we have and I believe Ray referenced it, a real workforce crisis. We chose to mitigate risk and enhance services by offering these positions to folks who had already demonstrated the needed skills in the community Kodak OTPs. It created an imbalance in the staffing configuration relative to experience in our other sites. And that was just the cost of doing that. The other piece, back to relationship and communication, is being able to look at contracts and have a relationship that allows the kind of trust to allow amendments to meet needs. The unanticipated costs associated with delays when hiring staff, as I had said before, such as an on-site dispensary staff or our nurse care managers, now any DOC position, new or existing. We've expanded the job description with a flexible start date at the prison and added a description of work at the community OTP so we can utilize the hired staff prior to their access to the DOC. And we won't be in that same overstaffing waste position that we were before. And also we are learning in terms of delays that what we believed was being proactive and timely in this particular case was being a bit rash. So we exercise more caution and pay a great deal of attention to knowing and respecting all the lines of authority for decision making at this highly complex hierarchy. Regulatory considerations, and I'm moving pretty quickly here. I know these are dense slides, but I didn't want to miss anything for you. The regulatory considerations on this slide are twofold. One is generally all of our state licensing regulations are designed to support a physical environment that's going to engage and provide patient-centered system of care. They are not designed to support a prison system. So in Rhode Island, where the regulations are fairly prescriptive, it was simply not possible for all those regulations to be followed within the context of the prison, such as numbers and types of clinical content, different types of documentation, toxicology requirements. So this is another example of challenge to integrating missions. Systems regulations at the prison support safety and security. They always, they have to supersede rehabilitation regulation. So again, that's why it's extremely important to involve your state agencies as you're developing the program. And then when we move into accreditation, we found that CARF, Joint Commission, COA standards, plus the survey process were not congruent with the correctional environment and system here in Rhode Island. So we learned always bring DEA, state agencies, your SSAs, your SOTAs into the conversation as the project is developing. One of the things we bumped into was we had to ask the DEA to come in twice to approve security because of what I referenced earlier in terms of the space for the dispensary itself being moved. And that impacts your DEA relationship. I would also suggest, and we will do this moving forward, is knowing which state regulations are not going to be able to be met and know what you need waivers for. Provide the rationale up front. If you put it right out in front of folks, it really saves a lot of time. And what we also found was we could choose an accreditation entity that did have that did have standards congruent with corrections environment and also has CSAT approval. And that is the National Commission on Correctional Health, the NCCHC, as one of the six, the NCCHC, National Commission on Correctional Health Care, is one of the six approved OTP accrediting bodies that has been approved by SAMHSA. It was done in 2004. The second edition of the standards came out in 2015. What's important to know about I'll move forward through this a little bit quickly. What's important to know about the NCCHC is that it is an organization that is really committed and very supportive of expanding MAT in the correctional setting. They provide technical assistance, and we're hoping that that's going to help us to further integrate MAT into the mission and organizational culture of the Rhode Island DOC. I included the website on the previous slide. Very easy to maneuver. The standards themselves are very easy. The whole book is only about 170 pages. And as I said, they're very committed to providing the technical assistance and increasing the number of OTPs providing MAT in correctional settings. And I'm just adding a bullet to again thank the leadership at the Rhode Island Department of Corrections and of leadership of Rhode Island in supporting the program. The second initiative, which will not take me as long to describe, is the Rhode Island Opioid Treatment Program Health Home. Rhode Island's Health Home was the second health home, OTP health home in the country. And Kodak was actually the first to be approved by CARF in the country, the first OTP health home. The goal, very, very common goals, you know them if you know CMS: hospital admissions, emergency room visits, nursing facility admissions, and need to decrease, and you need to have and use the NOMS measurements. And how are we going to do that? Here's a list. I'm not going to read it to you, but it's a focus on a fully supported, recovery-oriented system of care that's going to enable the system to meet the above goals and provide optimum health for those coming to us for MAT. The financial considerations, these were brand new services in Rhode Island. They had to be defined, they had to be reimbursed. So it was, we needed to build in outcome measures. What would the cost be? There were unknown utilization rates. We had no idea how many services the patients would want to use. We had no idea how much time it was going to take from the health home team members. So the configuration of time for different team members, pharmacists, docs, RNs, counselors, case managers, medical liaisons, all of that was an unknown. Okay, we needed to establish rates and codes, and the other major financial consideration with new rates and codes, because this was a Medicaid program, we were very concerned about the reimbursement competence of our managed care organizations. They're national organizations, and when you have something new, it takes time. That's another turning of the Titanic. There was also cost of accreditation, because now we had the accrediting bodies had created new standards for this program as a separate program. So how did we address them? One of the major things that we did, which I have to say Rhode Island, I'm hoping, continues to take pride in, is that all of Rhode Island's OTPs work together to create consistent programming. So we pooled funds for a coordinator that would be responsive to state and CMS requirements, reporting, and outcomes. We pooled funds for the development of a database, and the payment for these things was a unique and successful collaboration within all these organizations that we're usually driven by marketplace competition. I'm sure that many of you listening are aware of that. So we simply based it on the number of health home patients serviced in each OTP, because this information is gathered by our state agency. And that's how we divided the cost, and this has been successful for the last 4 years. Another way that we addressed the financial concerns was working with state Medicaid and Department of Behavioral Health, Developmental Disabilities, and Hospitals. They allowed us input into the design and to the cost of the services provided, and that's what this what this slide is referencing. And it allowed us to also learn some of the constraints. The very last bullet on this slide, we recognized how important it was to work within an existing payment structure, because otherwise we would be delaying the start of a new program by anywhere from 6 months to a year. When we were addressing the unknown patient utilization of service, one way that we did that, and it was very helpful, was in surveying eligible patients to ascertain wanted services. One of the mistakes that I know in the years, or decades actually, that I've been in the field is that we often look at our own perception of consumer need as opposed to listening to the consumers. And that's really, if you want to look at projecting utilization, it has to come from consumer perception. We found we had overestimated hours, and we worked needed hours, and we worked with state agencies to submit needed shifts in staffing configuration. And it worked. Again, regular communication with those that are in decision-making positions. We also learned a hard lesson, I believe, in addressing third-party payers, and that is that we really need to bring them on as well as soon as possible so that they're part of the process and there aren't delays in payment. We had delays in payment between 6 and 9 months at one point. And the last thing was aggressive community promotion for referral optimization so that we could refer our patients to specialty physicians in the community so that they would be comfortable referring back to us for those with opioid use disorder. And again, promotion, and enlisting state departments for that help. So basic principles again. Begin with all those who are critical to the legitimacy of the goal. Once the goal is determined to be obtainable, include all stakeholders and use your lessons learned. I'm going to try to move through this in about a minute. The last innovative program that I have here is our newest. The Health Home started in 2014. The Centers for Excellence, Rhode Island Center of Excellence for Treatment of Opioid Use Disorder. Kodak was the first in Rhode Island. We became certified in August of 2015. The COE, this Center of Excellence, I believe this is a pretty clear definition. It's a hub and spoke model with some differences to those of our northern neighbors. The financial costs we found that we were concerned about increased costs in reflecting services of the medical team. How would third-party payers accept this on the heels of the health home model? Again, we needed establishment of codes and rates. And the biggest one was how to manage insufficient fee-for-service reimbursement rates following the 6 months of Center of Excellence services. So the Center of Excellence as a hub and spoke model only allows the individual to be participating with the OTP Center of Excellence for 6 months. At that point, it is expected that the individual has the internal and external resources to return to the community or to be connected to the community. And at that point, a bundled rate goes away and we move into a fee-for-service model, which again, until rates are readjusted here in Rhode Island, are insufficient to cover service. So that remains a financial consideration for us, and we're watching it closely. Many patients don't want to leave, and we're not going to make them. And then we built on the existing expertise through the utilization of services of the health home coordinator, and just really aggressively got out there and talked to third-party payers and engaged community providers. We're still in the process of that. Examples of that would be the director of the Department of Health has invited us regularly to provider meetings, and we take our show on the road. The regulatory considerations were somewhat minimal. There were certification standards that have been created here by our Rhode Island State Agency. There are no national accreditation standards yet developed. As we know, accreditation standards really do help us assure effectiveness, but they also always involve cost. So again, building on existing expertise, building on existing relationships, closely monitoring what defined outcome measures there are, as well as cost center variables, because we don't have a lot of direction yet about what outcome variables we're going to be looking at, or outcome measures. We're measuring as much as we possibly can, because we've learned, and I think anyone listening probably knows, that trying to do retroactive data collection is ineffective and a nightmare. So some conclusions, and I will do this quickly. All three programs, as I mentioned last time, required culture and systems change. Also required an acceptance of the science that supports that process. Systems integration is required, and we need to work together with all stakeholder input in order to address this epidemic. And we need to recognize that we as OTPs are the experts in the treatment of this disease. We need to change our own self-perception. That's the biggest culture change. We need to move from a history of invisibility as a goal, and we need to move to a position of being very visible as experts in the treatment of opioid use disorder, which we all are. So just recognize we are indeed the experts, and you can see I'm being redundant because it's so important. We need to learn how to self-promote as a medical specialty with decades of providing evidence-based care. And that's going to help us impact public policy, regulation, and corresponding budgets, because in order to enhance care, there's a cost attached to it. And we are in the middle of an epidemic. So thank you. I really appreciate your time, and I hope this was helpful.
Linda, thank you so much. We greatly appreciate your time today as well. We do have a couple of questions, and we have just a few minutes to address those. So I'm going to throw them out here. The first one is for Ray. Ray, can you tell us how receptive are payers of behavioral health services to technology-based applications?
Our experience in that has been, I think there are two pieces to that. One is they've been interested in seeing some of the outcomes that we've been able to generate, incorporating technology, but also other things into care. Where that conversation starts to get a little bit stretched out is when you begin talking about sustainability and financial sustainability and reimbursement. We have had small successes in that, but you know, as with so many other sort of negotiations with payers, once you get the bean counters in the room, they see some of these as additional costs. It's hard for them to see value. I think alternative payment models ultimately provide the best hope for incorporating these and other approaches into the care delivery and outcome improvement. But that has been challenging.
Okay, great, thank you. Another question for you, Ray. In the context of the Recovery Track app that you mentioned, are there any studies that look at the recovery durability using technology versus in-person or group-based support?
You know, I don't know of any. That's a good question. I think we see this. I mean, and one of the reasons why I haven't spent a lot of time delving in that is that we see this as being not exclusive but complementary. I think, you know, we have a tendency in our field, at least in more recent years, to be looking for, you know, one-offs. So medication is going to solve everything. Well, it's going to be a part of a more comprehensive approach to care, and I think that's also where the technology piece lies also. but I don't have that piece. A good question. I'm gonna look into that more deeply after this.
Okay, great. All right, Linda, one question for you. For a person who enters the opioid-specific health home, how are her or his services paid for? Are those covered by Medicaid?
Yes, both the Health Home model and the Center of Excellence model were Rhode Island Medicaid projects that evolved out of a state plan amendment to CMS, and it's a bundled rate. So that's why it was so very important for OTPs, or Kodak in particular, to be part of the conversations in defining what services were needed, who needs to provide them, and what will the cost be. So actually, again, I'm going back to self-promotion, us self-promoting as the experts and saying we need to be at the table in order for this to be a sustainable program was critical. And then once we negotiated this with our own internal state agencies and it was approved by CMS, we went to commercial insurers and said, here's a bundle, here's a package of services for folks, and other commercial insurances also created codes and rates for us to provide the service.
Okay. All right, great, thank you. All right, I think those are all of our questions, and actually it turns out that's a good timing for us to stop here. Just a reminder, we have an upcoming webinar August 9th. It's the final in this series of 5. This will be addressing action steps for implementation, where we're hoping we can sort of pull all of our information that we've heard over the previous 4 webinars into a discussion of defining the workflows and procedures, staffing, staff re-education, patient outreach, and monitoring outcomes, and really looking at where do we go from here now that we've heard about how to do these various models and implement various activities and care coordination. What's our next step, and how do we take it to the next level? Registration link will be sent via our Health IT Webinars listserv, and you see the email there on your screen, healthitwebinars@abtassociates.com. If you are wanting to be added to the list, please email that email address and we will add you so that you get upcoming updates. All sessions will be recorded and posted to the SAMHSA YouTube page. On behalf of SAMHSA, I would like to thank everyone for joining us today. Thank you very much and have a great day.